welcome you to the New America Foundation. And thank you for joining us this morning for the release of the 2008 Child Wellbeing Index and our discussion, Are America's Teens Better Off Than Their Parents? We have been pleased to partner on this initiative with a great leader in the field, the Foundation for Child Development, and we appreciate their support of this initiative. The Child Wellbeing Index is a comprehensive report of the overall well-being and quality of life of America's children, compiled each year going back now towards 1975, and it provides an important research-based look at the status of children in the U.S. over the last 30 years. And we're pleased to help present the 2008 release. In addition, this morning we'll have a special emphasis on how teenagers have been living in this decade compared to how their parents were doing at the same age. It should be a lively discussion. So this morning, Dr. Kenneth Land, a professor at Duke University and the author of the CWI, will present the results of the most recent version, as well as the results of his generational comparison. And then we're pleased to present what will be an excellent and experienced panel of respondents, to be followed by your questions. But first, let me introduce Ruby Takanishi, the president of the Foundation for Child Development, to say a few words. Ruby?
Thank you very much, David, and to the New America Foundation for hosting this 5th annual release of the Child and Youth Wellbeing Index, the CWI. The Foundation for Child Development has supported Ken Land and his colleagues at Duke University since 1999 to develop the CWI, to update it each year, and to project its future value. We're very appreciative to Ken Land and to Professor Vicki Lam and their work for close to a decade now to devising a way for how the United States can monitor the overall well-being of its children and youth over the past 30 years, from 1975 to 2006. And we also recognize the work of other researchers who have contributed to its refinement and using the CWI in their own research to look at racial and ethnic inequalities. The goal of the CWI effort is to provide us, citizens and policymakers, with a big, comprehensive picture of how American children are doing over time. Not just looking at single indicators, but their interrelationships, and how an evidence-based approach can be used to determine how much better the United States could be doing with respect to children's well-being. I think one significant finding already over the last few years is the role of economic conditions and its interrelationship to children's well-being. And as Ken Land concludes, there remains substantial room for improvement. In closing, let me express my personal delight in the special focus report on intergenerational comparisons of adolescent well-being. The Foundation's work builds on our own work in founding the field of childhood social indicators, and especially to the work of FCD President Burt Brim. But it also builds on the work of the Carnegie Council on Adolescent Development, which had the big goal of raising adolescents higher on the national agenda. To now have a data-based picture of how conditions have changed for American adolescents over 2 recent generations tells me that we can make progress in charting how well the United States is doing to support its young people, what can make a difference, and where we need to invest. The picture is decidedly mixed, some progress, but not enough. And I must conclude that we must be ever vigilant to what is happening to America's young people. Progress is not eternally assured, and be prepared to adapt to changing conditions. And I would now like to introduce the principal developer of the Foundation for Child Development CWI Index, Professor Ken Land of Duke University. Ken?
As Ken comes up, I'll remind you there's both cookies and refreshments here, as well as a copy of the recent index, also on our website, on the Foundation for Child Development website. And the USA Today has an article on the results of the index as well, which you can pick up as you leave as well. Ken?
Great. That is, yeah, forward and backward. Okay, thank you, Ruby, and thanks to all of you for attending today. I hope you'll find what we have to say today interesting. I do want to acknowledge collaboration with Dr. Vicki Lamb, who's in the audience here, and who will take questions later on. Okay, without further ado, let me get on with the presentation. Just to review for a moment, what is the CWI? It's a composite measure of changes in the quality of life or well-being of America's children and young people since a base year, 1975. Consists of 28 social indicators organized into 7 quality of life domains. And it addresses questions such as the following. Did overall child and youth well-being in the U.S. improve or deteriorate over the past 2 generations? By how much? Can we give some at least tentative quantitative measure to that? And which domains or areas of social life? For which age groups? For boys and girls equally? For racial and ethnic groups? And did disparities among groups increase or decrease? The methods of construction are quite simple and straightforward. It's important that these be public and as simple and transparent as possible. We place our 28 national level indicators into the 7 quality of life domains. These domains have been well established in the subjective well-being literature, studies of happiness and life satisfaction, including numerous populations from adults to children to adolescents. Family economic well-being, health, safety behavioral concerns, educational attainment, community connectedness, involvement in social institutions, social relationships with family and peers, and emotional and spiritual well-being. Each of the 28 indicators uses annual time series data from vital statistics and sample surveys. Each indicator is indexed by percentage change from the base year 1975. Base year is assigned a value of 100, kind of like a consumer price index, and a value greater than 100 indicates the social condition has improved, and less than 100 a decline or deterioration. The 28 indicators are grouped into the 7 domains to construct 7 summary well-being indices. Within these summary indices, each indicator is equally weighted, and the 7 domains are combined into an overall composite index, the CWI. Each domain is equally weighted in the construction of the CWI. Why do we use equal weights? Well, it turns out we've done a statistical analysis of weighting procedures, and the equal weighting procedure is a so-called minimax estimator. In statistical terminology, it minimizes extreme disagreements among individuals as to the weighting schemes. So what does the composite index, the CWI, tell us about trends over time? Here's the chart that shows the overall changes since the 1975 base year. Those of you who've been here for these presentations before have seen our earlier reports, know that the CWI was kind of oscillating around a stable level in the late 70s, then went into a long-term secular decline, a recession if you will, and then a substantial recovery in the mid to late 1990s, and since a peak in the year 2002, slight declines, and more recently slight increases. We're in a kind of stable, stagnant period here, and we project that to continue with only a slight moderate change in 2007. The domain-specific indices are here. I don't have time to dwell upon each of these in great detail in this presentation, since I want to focus on the intergenerational comparisons, but the printed report, of which you have copies, does go into the changes over time in the domain-specific indices as well. I must mention that when we look at the projection for 2007, we have some misgivings of this slight increase that we're projecting for 2007 may be there, but we are of course facing looming macroeconomic concerns that began in 2007 with the housing finance crisis, and more recently energy prices, inflation, and food and energy cost, and job losses. And we think that while we may see a slight change upward for 2007, We may also in 2008 and probably in 2009 see an impact of the current macroeconomic adverse conditions, kind of like we saw in the early 2000s, and so that probably will turn into a 1 to 2 point decline in the overall CWI for the period 2007 to 2009. Now again, that's a projection based upon past experience, and only time will tell when the numbers actually are available in a couple of years. Now I want to go on to our special emphasis report for today, and this compares echo boomer adolescents, children of late baby boomers especially, with their baby boomer parents, and addresses the question, how does the well-being of teens in the early 2000s, in particular we take averages over the 3-year period, 2003, 2004, 2005, we take an average to kind of smooth out any particular fluctuation that's unique to a particular year, and we compare those averages, recent averages, with those of a generation ago, namely 1975, 76, and 77. And that separation is roughly 28 years, and that's about the modal age of childbearing in recent decades. And so basically it's a intergenerational comparison of adolescents in the early 2000s with their parents from a generation ago. And if you look at the charts in the report, you see that we have a number of comparisons. The first one here is the poverty rate for ages 12 to 17 for the years 75 to 77, the 3-year average, compared with the 3-year average 2003-2005. And you see that we've lost ground slightly here, and indeed America's long-running war against poverty, if anything, we have ceded ground to that, at least with respect to adolescents in recent years as compared to their parents a generation ago. On the other hand, there's some good news here as well. And one of the charts that shows some really good news is the decline in the mortality rate. And this chart shows ages 10 to 19 for 1975, 77, 2003, 2005, from 61, let's round up to 62 to 38. That's a dramatic decline over the generation. And much of that, of course, relates to declines in accidental deaths, some improvements in treatments of diseases and health in general, but it's a dramatic decline over a generation. And that's a piece of good news. On the other hand, on the same chart here, we show some of the bad news. And this is the growth and prevalence of obesity and overweight children, in adolescents in particular, from about 5.74% to 17.6%, a tripling across the generations. More good news here. This is a teenage birth rate, violent crime victimization rate, and offenders rate for the years 75 to 77 compared to 2003, 2005. Again, good news, substantial decline in the teenage birth rate. Of course, that's not victory. There are far too many teens, even in recent years, giving birth to children. In terms of the obstacles that are faced and the consequences for the children, we know that's generally not good, but nonetheless the substantial decline is quite impressive. Violent crime victimization is another piece of good news, going from 84 per 1,000 to 48 per 1,000, quite substantial decline. This is consistent with the violent crime offender rate from about 33 to 15. These data points are from the National Crime Victimization Surveys, and again show substantial declines across the generations. From the Monitoring the Future survey at the University of Michigan, we get corresponding comparisons for, in this case, 12th graders. Since 1991, they've also had data on 10th graders and 8th graders, but we use for consistency for the intergenerational comparisons 12th grader data. And cigarette smoking is down substantially again. Binge drinking, 5 or more drinks per session. Alcohol drinking is down very much as well, as is illicit drug use, the intergenerational comparisons. Here are some indicators of community connectedness, participation in social institutions, connections to social institutions. A particularly important measure is the percent of teens either not working or not in school, ages 16 to 19. So this is the percent not connected to schooling or economic institutions. And that's declined from 10.5% to 8.23%, which again, in a percentage basis, is a nice decline across the generations. We've made very little progress in high school diploma rates. As many of you in the audience know, we still have enormous problems of school dropouts, especially in urban school systems. And so the percent increase here across the generations is from about 81% to about 83%. And that's a slight increase, but still much room for improvement. Bachelor's degrees, 23% up to over 28%, a nice improvement there. How about performance on test scores? Fortunately, the National Assessment for Educational Progress provides us with longitudinal data on reading and math that we can compare across the generations. And we do this for 2 age groups here, age 13 and age 17. And you see for the reading scores that at age 13 there's a slight improvement, but we lose that by age 17. On the other hand, for the math scores, there's a substantial improvement at age 13, and by age 17 some of that is retained, although not as large an increase as you see at age 13. So basically, kind of good news for the math scores. We've lost ground, at least with respect to 17-year-olds, for reading scores. Measures of emotional well-being, suicide rates are roughly the same. We did go into a period in which suicide rates for adolescents had been substantially elevated compared to the 1975 base year, but in the early 2000s we were back just about to the level of a generation ago. Meaning in life is often part of an aspect of participating in a religious institution, a religious tradition. If we compare across the generations here for 12th graders from the Monitoring the Future study, we see a decline in religious attendance, but at the same time an increase in the percent who think the religion is important. I would say that's characteristic of adult trends as well across this generational period, and so teens in a sense are consistent with their parents in that respect. So in terms of conclusions, Echo Boomer adolescents as compared to their Boomer parents, slightly more likely to live in families below the poverty line, test scores in reading and mathematics only slightly higher than those of their parents. On the other hand, much lower risk of deaths from accidents, violence, or disease, more likely to be overweight or obese with associated health problems and risk. Same time, they're much less likely to participate in risky behavior, bear children, be victims of violent crime or offenders, and smoke cigarettes, binge drink, or consume illicit drugs than their parents. At the same time, also more likely to participate in school and economic institutions. And so now we ask the rhetorical question, what's going on here? And do these intergenerational change indicators basically tell us that Boomer parents have told their kids, don't do as I did, but do as I say? And
a lot of these
I thought this would be kind of
cultural
amusing
crimes I've been
to let you
complaining
see
about
this. This is
can be
George
blamed on the
Carlin.
baby boomers.
Just
Something else
riff
I'm
on
a
the
little tired
boomers.
of hearing about. The baby boomers. Whiny, narcissistic, self-indulgent people.
guys. Is it going to play?
A lot of these
I'll try
cultural
again.
crimes I've
I'll
been
leave this
complaining
alone.
about can be blamed on the baby boomers. Something else I'm a little tired of hearing about. The baby boomers. Whiny, narcissistic, self-indulgent people.
Justin.
Try one more time.
One more time? Okay.
Go back and see.
Seems like it's hanging up there, guys. It's a great riff.
A lot of
We could
these
get it to play.
cultural crimes I've been complaining about can be blamed on the baby boomers. Something else I'm a little tired of hearing about. The baby boomers. Whiny, narcissistic, self-indulgent people.
That's stopping, guys.
It's baby boomer technology.
Now we're really,
This was a great riff. I'm sorry.
Improv it. Improv it. You can do it.
As we all know, George was had a great command of the English language and was a great social critic. And in the riff, he basically talks about how boomers went from things like do your own thing to just say no. And how they had one abiding philosophy, which was, give me it, it's mine, and so forth. And so it's a great riff. I'm sorry it doesn't play the whole thing, but in any case, we asked the question, well, did George have it right? Was he more perceptive than the rest of us? And we can have an interesting discussion of that in a moment when we open this up for general discussion. At the end of the report, we point out that, you know, our comparison is 2003-2005 averages compared to a generation ago. And of course, we're now living in 2008, and we're a couple of years beyond 2005. So is there something that's happening more recently that, that we need to focus on? And so that's in the last part of the report. And we asked this question, will these good trends, intergenerational comparisons up to 2003-2005 continue? And we identify 3 portents of changes that we need to be very sensitive to and keep an eye on the next couple of years that we need to monitor very closely, and as pertains to the well-being of adolescents. First, there may be increases in poverty in the offing for today's adolescents. As I noted at the end of the report on the update for the CWI, we have these looming macroeconomic changes since 2005. And they're likely to hit with pretty full force in 2008, and since it takes time for these things to work out, in 2009 as well. So those are there. But in addition, in our indicator database, we have refinements of the 28 series that we use in the CWI, and in particular we look at child poverty trends and adolescent poverty trends by composition of family. And it's in particular, we identified here the percent of all single-parent families in poverty rose from 32% in 2004 to 32.3% in 2005. And it also went up in 2006. And in particular, this may be a leading indicator of more general family economic stress during the 2006-2008 period. Now, I want to point out to you that, you know, the thing about these percents is that looks like a small change, 0.3%, but it's on a large population base. And when you translate the change from 2004 to 2006 into population numbers, you get about 160,000, okay, increase of 160,000 adolescents living in single-parent families below the official poverty line. And so that's not inconsequential. Second, there's a new wave of increases in teenage childbearing that may have begun. Preliminary estimates show this indicator increase in 2006 in contrast to declines recorded for the years 1991 to 2005. Specifically for ages 15 to 17, the number of live births per 1,000 females rose from 21.4 in 2005 to 22 in 2006. Again, that looks like a small numerical change. It's a 3% increase, but translates into substantial numbers. This increase was recorded both for non-Hispanic white and African American teenagers in this age group, so it's not due to an increasing prevalence of Hispanic females in the population with a different cultural heritage with respect to teenage childbearing. Third, there may be reversals in other safety behavioral indicators in the offing as well. The rate of violent crime victimization per 1,000 adolescents rose from 44.15 in 2005 to 49.8 in 2006. And this followed a rise in the rate per 1,000 of violent crime offenders from 13.6 in 2004 to 17.2 in 2005. Illicit drug use among 12th graders also increased from 2006 to 2007. And so we're trying to detect some early warning indicators here of potential changes in the more recent period, 2006 and beyond. And this is one of the virtues of the Child Wellbeing Index work. We do not view our individual time series as discrete indicators that have no relation to each other. Rather, they're all related to each other through the well-being construct. And so things that happen in one area of life can affect things that happen in another area of life. And in particular, with those increases in adolescents living in families beneath the poverty line that we see from 2004 to 2005 and 2005 to 2006, these children, we know from numerous social science studies, are at greatest risk of all kinds of risky adolescent behaviors. And it's perhaps no accident that we're picking those up in the other two portents that I identified here. And we can have an interesting discussion about the uptick in teenage childbearing. Does it relate to inadequacies and deficiencies of pregnancy prevention programs? Does it relate to pop culture, and in particular recent teenage celebrities who've become pregnant and movies about the topic and so forth? Which is the cause, which is the effect? We can have an interesting discussion about that. I would only remark that once those elements of the popular culture are there, they can have a positive feedback loop to affect subsequent behavior. And so we need to be very sensitive to possible additional upticks in that particular indicator. I'm going to conclude at this point and let the panel discuss additional details, and we'll take it from there.
Ken, thank you very much, both for your excellent report and for that presentation of the report and beginning of our discussion here today. Sincerely apologize that technology did not work on the late George Carlin riff. However, when we put this event on the Workforce and Family website, we will attempt not only to have that riff up, but perhaps to the original George Carlin hosting of the very first Saturday Night Live in 1975, because then you can get a generational comparison of George Carlin's performances in 1975 to those more recent. Secondly, I do think the point, though, that you made about baby boomers is important, about how they were when they were kids, as well as the impact they have had on today's teenagers. And so as we begin to focus on the well-being of today's teenagers and drill down into both what is causing some of these factors that Ken has just talked about, and perhaps more importantly, where we go from here in terms of addressing and dealing with areas of where there are problems, we're very pleased that we have four excellent panelists who have taken the time to be with us this morning. I would encourage the four of them to come up now and take a seat and get ready. And as they do, I will just say two things. First, we're beginning to get a packed house here, and we're starting to run out of seats. For the New America folks, there are more chairs in my office and then down to the right. Secondly, there are near the front also biographies of our four panelists as well, and I will not go into complete details because you have copies of them, but just as the four come up, Lar Kwong is Senior Advisor on Children at the U.S. Department of Health and Human Services. Anisha Abram is the Chief of the Section of Adolescent Medicine and Assistant Professor at Georgetown University Hospital. Anita Berger is a Principal of the Benjamin Banneker Academic High School here in Washington, D.C. Kelleen Kay is the Research Director at the National Campaign to Prevent Teen and Unplanned Pregnancy and a Fellow here in our Workforce and Family Program. So if you all come up and join us here, if you would, we'll start with Lark and then go from there. And then when they each talk, then after that we'll have your questions and comments, and we'll look forward to our discussion. All right, Clark, the floor is yours.
Okay, I do have a...
You do, yeah. And I would just,
Do you want us to speak there? Or?
I think I would encourage you to,
Okay.
to speak up here and maybe use this right clicker is what starts it.
Okay, good morning. I'm really pleased to have the opportunity to be one of the panelists to respond to this report. I thank Ken for an excellent report. I thank Ruby for her tremendous work on child indicators. Over the decades now, it's been real important for us in terms of setting public policy. I do want to make a correction on my introduction. I'm not the senior advisor to the whole Department of Health and Human Services. I got elevated here, I guess. I am the senior advisor on children and youth and families in one of the agencies of Department of Health and Human Services, and specifically in the Substance Abuse and Mental Health Services Administration, more frequently known as SAMHSA. So I'm real excited about this report, and really, in spite of not being able to hear George Carlin, who I can dig up from the past, it's really exciting to me because it's an intergenerational report. We often don't get sort of looks at two generations, and one of the things we're trying to do at our agency is do more interventions that are actually multi-generational focused. The second thing, it has personal meaning for me because I'm one of those baby boomers, but I'm a little bit older than those boomers. But I had kids late, so those are my echo boomers. And so when I lecture, reprimand, or whatever to my kids, I can draw on, evidence-based data now. And they love that, yeah, right. So it's really exciting how you've really looked at this data and the particular take you've put on it. In my comments, I have sort of 4 categories of comments. I was asked to respond to a number of different things. So, okay, here we are. So my comments, I'm going to really speak to, one, I think there's really multiple Americas, and when we look at indicators, we need to think about what is the lived experience and how do those indicators play around different race, ethnic, and regional groups. The second thing is in terms of looking at age cohorts. Again, when you aggregate an indicator, you might obscure some of the differences around different developmental groups. The third thing, which Ken has mentioned, is that these are not discrete entities, that these behaviors, whether they're the risk behaviors, they really occur in clusters. And then fourth, I was asked to address a little bit about what might be working in some of our programs and some of our initiatives. Why do we see, to a certain extent, sort of positive developments from one generation to the next? Okay, so in terms of, I just want to talk about multiple Americas. There were some recent articles in health disparities work that's really saying if you look at mortality rates and disparities in those, mortality morbidity rates, you see real differences in terms of race and region. So I want to just say that we have a demographic imperative in terms of the changes in our population, and particularly in our youth population, because you see the percentages of growth are going to be very striking, particularly for Hispanic and Asian American. Asian American is a smaller population at about 4%, but their rate of increase is going to really accelerate in the next 10 years, as well as with Hispanic, in comparison to lower rates of increase among the white Caucasian youth population. And I actually had a slide, but I felt I had too many slides. I did have a slide that spoke to what Ken was talking about in terms of poverty rates by family composition, and we really see different rates. You can see the different rates here by race and region. When you break that down into single parent versus two parent, particularly among youth of color, you see dramatic differences, almost doubling the rate of poverty of those children living in single parent families who are of color versus in two parent families. You also see that in rural areas, we have high rates of poverty, particularly among youth of color. Okay, so almost half of youth of color in rural areas are living at the poverty level. This also comes from the National Center on Children and Poverty, and they also have looked at regional differences. And you see, again, there's small increments, but as Ken says, we're talking about large populations, so a small percentage increase can be very significant. So if you look at this regional data by poverty, you see actually that in 3 regions of the country, the poverty rate is going up for children. Wanted to also, there was the indicator in terms of health. I think was one of the indicators that actually went down over the generations. I wanted to just pull out a particular condition that affects young people, and particularly youth of color. And you can see, if you look at asthma, you see real disparities in the prevalence of asthma by race, ethnicity. And it's very interesting because SAMHSA is trying to do more work. We're collaborating more with CDC, the Center for Disease Control and Prevention. So we've been really looking at the public's health in a different way, not just in the public health system, but the public's health that needs to be taken care of by multiple systems. So the Los Angeles Director of Health was presenting to us on asthma, where they were geomapping and tracking asthma, and found it high in schools that were built within 500 feet of freeways. A lot of inner city schools, a lot of inner city kids. So they now have taken that data and have a policy where they're no longer building schools within 500 feet of freeways, and think that will have a tremendous impact on their rates of asthma. In terms of some of the safety behavior indicators, again, as Ken mentioned, that was a slight improvement, 2004 to 2005. But then if you sort of begin to disaggregate this again, we see homicide rates actually going up among black youth males, and also an overrepresentation of youth of color in incarceration in juvenile corrections. Underage drinking, and looking at trend analysis, as Ken said, we see a slight decrease in this since 1970s. Which we can applaud our kids for, maybe. But you see again that more stability or plateauing currently now. At the same time, and this is something that the Surgeon General has come out with a call to action on underage drinking, because while we're not seeing uptakes in that, we're also seeing a huge percentage of kids engaging in underage drinking and in binge drinking. So I couldn't help but resist saying that even though we see the trends downward, we see the proportion of kids still very high, and we see other factors. I mean, it is a behavioral issue, but when you look at the beverage industry and that 37% of sales, amounting to about $22.5 billion, are to youth, we see that there are other factors we're talking about in terms of really making improvements in public health. I also wanted to show you this slide, which really begins to disaggregate. And this comes from, we do an annual survey on a national survey on drug use and health. It's a household survey every year, about 75,000 households interviewed. And that when you see here that the rates of alcohol use, and you see it's highest among white youth at 32% white youth. But when you begin to dig a little bit deeper and you look at the number of days of alcohol use, okay, on average, break it out by race, ethnicity, you see that 8 days of underage drinking for Native Hawaiian Pacific Islanders tops, compared to the lowest being Asian. Then when you look at the number of drinks on those days they're drinking, and this would be like a binge drinking kind of piece, is you'll see again the Native Hawaiian Pacific Islanders highest, African Americans the lowest at 2.8. Native Hawaiian Pacific Islanders drinking about 6 drinks on those days, those 8 days that they're engaging in underage drinking in the previous month. We also try to look at this in terms of state data. States are often interested, so they have their own indicators. We break this out by sub-state data. And you can see the darker maroon is the higher rates, anywhere from 13 to 15% of youth engaging not just in alcohol drinking, but this is in binge drinking. And you'll see these patterns around the states, and you'll see we plot a lot of our indicators by state. What's interesting, if you look at Utah, okay, Utah is that white state in the middle. Okay, now if you think about, okay, some of their cultural prohibitions against drinking, against drug use, against early sexual behavior in Utah, but Utah has one of the highest rates of prescription drug abuse among youth. So that is not part of their culture. They have access to prescription drugs, which we're seeing really going up among adolescents. Okay, so patterns of drug use. Up to about 1997, we saw steady increases in illicit drug use among youth. So that's some of us, you know. So, but then we begin to see an overall decrease. But since 2000, we're seeing a different pattern of illicit drug use. Increases in methamphetamine, particularly in rural areas, particularly in lower income areas, because you can make that drug, you can cook that drug at home. So we see increase in club drugs and high increase in abuse of prescription meds and prescription narcotics. We're seeing high rates of overdose among youth due to prescription drug abuses and prescription drug pill parties that are increasing. And so you can see the CDC data on that too. Wanted to also just give you this slide again, breaking out by race, ethnicity in terms of illicit drug use. In terms of suicide, and as Dr. Land said, we've seen a plateauing off of that. We still have 30,000 suicides per year in our country. About a fourth of those are youth suicides. But if you look at the far left end of the scale, and this is CDC data, you'll see that if you break it out by race, ethnicity, you'll see over the life, this is over the age span. So if you want to just look at the first half of that graph, you'll see that American Indian, Alaska Native, high rates of suicide, particularly in youth. Okay, and I'm sure you've all read about suicide clusters on reservations. You'll see that that does start to plateau downward with developmental age. But you can see that many of our youth are at high risk here in terms of suicidal behavior. When you look at it, when I just look at it in terms of males, again, this is the pattern by race, ethnicity. In terms of looking at major depressive disorders, and again, we look at this by, you can look at a state breakdown, and I put this on here because depression is one of the risk factors for suicide, and depression, and particularly we find with youth, many of the suicides are also accompanied by alcohol use. Okay, just wanted to say something about cohort differences as we look at indicators, and this is really focusing on young children. You'll see that young children, age 0 to 5, much greater rates of young children living in poverty or in low-income homes. Steve will like this. And also, when you look at risk, if you look at foster care children, we have about just over 500,000 children who are actually going into foster care now. The greatest percentage of those are children 0 to 5. So if you think about that for the regular developmental trajectory of health, and when they're being removed from their homes multiple times, young age, we do have issues here. Clusters of behaviors. These behaviors don't occur alone. We know that kids who are depressed are 2 times more likely to initiate substance use, illicit drug use, and sexual behavior. We know that alcohol is often very much in a factor involved with crime victimization as well as crime perpetration. So we're asked to say, well, what's going on? What can explain some of perhaps the positive declines in risk behaviors over the generations? And I just wanted to underscore here again this idea of a public health approach that is not mainly just the responsibility of the public health care delivery system. So not just our health care system, but really partnering across sectors with other systems, perhaps in a public health approach that looks at early warning signs, looks at outreach and engagement, treatment, recovery, aftercare services, but really going across into the justice system, the education system, the faith-based system. And that's what some of these have been major programs that have been funded by the government over the last couple of decades in terms of really funding communities to be drug-free communities, giving grants to communities to develop partnerships to address a particular risk behavior in the communities, whether it's underage drinking, illicit drug, youth violence. And it's really come from cross-sector partnerships. What's been really critical of this, it's not owned by any one particular sector, but working with the Department of Health and Human Services, collaborating with the Department of Justice, with the Department of Education, and then mirroring those kinds of collaborations at the state and at the local level with a lot of increasing more faith-based organizations involved in this. So, sum up the implications for policy and practice. I'm getting the stop sign here. I think we really need to underscore that our economic policies, our social policies, our health policies all contribute to the well-being of our youth. It's not just our health policies, it's not just our school policies. I think that actually as we're more globally interwoven across countries, we're going to have to really look at some of the indicators in terms of international work as well. Adverse childhood experiences study, I'm not sure if you're all familiar with that, but it's a really critical study that looks at what happens in youth and the number of adverse experiences, whether it's divorce, whether it's living with someone who is an alcoholic, living with a drug abuser, living with somebody with mental illness. The more of these ACEs, they're called, adverse childhood experiences, are associated with not just substance use, but health outcomes. So that if you have 4 or more of these ACEs, you're 60% more likely to have a lung disorder. Okay, scores of 6 or more, you're 400% more likely to be an injection drug user. And this is a study that was done on 17,000 Kaiser patients in Southern California. So it wasn't a clinical population. It wasn't a population that was coming in for trauma or anything. This was a normal, healthy population looking back at what kinds of risk factors did they experience as children and how it predicts, is very predictive of health outcomes in adulthood. We have reached plateaus on some of these indicators. As Ken said, we've kind of plateaued out at, for example, underage drinking. So what do we need to do differently? Since we've decreased, but we've plateaued, we still know there's a large number of kids engaging that. What different kinds of new strategies do we need to think about? Thank you very much.
Thank you, Lark. I appreciate the piece about partnerships and the role that we all play in this and in partnerships. I was in government. I appreciated working with SAMHSA on a number of initiatives, and I thank you for coming and sharing that wisdom with us. Dr. Abraham is a leader not only in this, in Georgetown, in adolescent medicine, but the entire D.C. Chesapeake region, and so I'll ask her to come up and talk next. Thanks.
I'd like to thank the New America Foundation for inviting me. It's certainly an honor to be here among such distinguished panelists. I'm an adolescent medicine physician, and I work in clinical practice here in D.C. I see teen patients both in an academic center as well as in an inner-city school-based clinic. And part of the reason I chose to pursue adolescent medicine is because I think it's such a rewarding field. That there's such a tremendous hope that you can have from working with a young person, working on an individual level, making connections, certainly helping them to avoid some of the high-risk behaviors that they can do. I think that Dr. Lan has outlined some of the tremendous progress that we've made over the last 30 years in terms of working with young people. But as a physician and certainly someone that's working with teen patients, I would also like to say that there's so much more that I think we need to continue to do. And I'd like to spend a few minutes this morning commenting on 2 particular issues which I see and I struggle with some of my teen patients. And that first issue is obesity, and as we have heard this morning, we certainly know that there's been an increase in the number of young people that are obese. And the second issue, which I have seen much more in my clinical practice, is young patients that are coming in with issues of mental health. We certainly have an unmet need when it comes to both obesity and mental health issues, and I'd like to elaborate on that just a little bit more. Now, the CWI that we heard this morning shows that teenagers are 3 times more likely than a generation ago to be overweight. And in fact, what the rates we saw was that it went from 5.74% for teenagers that were ages 12 through 19 in 1975 to 1977 to 17.6%. And this parallels data that we know from other surveys, including the National Health and Nutrition Examination, or the NHANES data, which shows very similar rates in terms of increases among obesity among teen patients. And of course, there's disparities among populations, so those numbers actually increase in certain populations. So if you happen to be a non-Hispanic female, particularly from African American community, those rates go up to 25% in terms of teenagers being obese. And so these are very high rates that we're seeing in young people. And what I think is particularly alarming is that these young teenagers are much higher rates or risks of becoming obese as adults. And in fact, one study has shown that about 80% of teenagers go on to become, if they're overweight as a teenager, go on to then become an adult as a teenager. And certainly there's lots of complications that can occur as one becomes an adult with obesity, and that includes things such as cardiovascular disease, hypertension, diabetes. And what I would also like to remark on is that we're seeing more and more teenagers and even children in our practice that are now presenting with things that we historically thought about in adults that were 50 and 60, but now they're coming in as teenagers and having to be treated with cholesterol medications for diabetes, all real significant issues that, again, we would have really thought much more in our adult population. I'd like to use one case as an example, and it's a 17-year-old female, and for the purpose of our discussion, I'm going to call her Mary, but it's certainly a teenager that I've worked with very closely over the last year and a half. And in fact, Mary came to our adolescent clinic initially because she had something called pseudotumor cerebri, which are headaches that sometimes can be a complication of obesity. And in fact, these are headaches that are caused by extreme pressure in the brain. And what was very encouraging is that Mary was actually able to be treated for the headaches and for the pseudotumor cerebri. What turned out to be much more challenging was actually to treat Mary for the underlying cause of her headaches, which was obesity. And in fact, we struggled a lot. Mary comes from a family where she doesn't have a lot of support. She also comes from a family with a significant family history of obesity. And where she comes from, there's not a lot of resources in terms of nutritional counseling or even access to good nutritional foods. She told me in one of our discussions that the best place for her to actually get her meals on a regular basis is from the local convenience store, the 7-Eleven, or from maybe one of the fast food restaurants, because there actually aren't any grocery stores in her community that serve fresh fruits and vegetables. And as much as we as providers tell them about eating regular meals and certainly having fresh fruits and vegetables, one day she said, you know, Doc, it's so much more expensive for me to buy fruits and vegetables than it is for me to get Doritos or to get fries or to get a burger. And so I certainly think these are some of the challenges that we have when we talk to young teen patients in terms of overcoming barriers and really getting them to get access to the right things. Certainly other issues that I've seen with Mary have included complications. She now has irregular periods, she has diabetes, she has high insulin and cholesterol levels, and these are all complications that occur with obesity and certainly things that are really difficult. And she's had a very hard time finding resources to get in and to make any changes in terms of her weight. Her school actually doesn't offer, there's been a cutback in the amount of physical activity that's been offered at her particular school. And she finds it very difficult to go to any kind of a gym or find a girls' club or YMCA in our local area. And in fact, it's not very easy for her to find or afford any other programs. And once we actually joked maybe she needs to contact Oprah Winfrey and see if there's another program or some other place that she could get to and maybe make some changes in terms of getting a personal trainer or something like that, because it's been such a bleak outlook for her in terms of trying to get access for her actual care. Her case certainly illustrates some of the causes, I think, of obesity: a family history, a lack of resources in terms of good nutritional foods, decrease in activity levels, and certainly in access to other things that can really help with weight. I'd like to say we've made some progress in her case. One of the things that we've been able to do since we've worked together is to cut back on what I call her screen time. So when I first met Mary, she was watching probably about 5 hours of TV, and that probably doesn't include the amount of Facebook and MySpace and other things that she's also doing. And believe it or not, the average amount of time that our young patients are watching TV these days is about 4 hours a day. And they say that if you live to about 70 years of your life, that's about 7 years of your life. So again, some of the statistics that we're actually seeing with our young patients, and one of my personal things that I work with my teen patients is really trying to get them to decrease what I call their screen time or their TV time. One of the things that Mary's also started to do is to increase her own activity at home. And my personal favorite is something called Dance Dance Revolution, which is, if some of you have probably heard of that, it's actually a video or music that you can actually dance to it. And that was one of the ways that she found as a creative solution to being more active in her own home, not having to go outside, but certainly increasing her activity. But I do think that her situation really illustrates the fact that we need to have more access from certainly a public health level in terms of increasing nutritional food, increasing activity, increasing resources, and certainly making obesity an easier issue for our teen patients. But right now, there are certainly many obstacles that I think we need to combat. Now, Mary struggles with another issue, which leads me to my second point of my discussion this morning, and that's depression. And Mary, as she's been dealing with her obesity, has certainly felt very down, has been teased, has had a lot of issues in terms of her own mental health. And what we know from the CWI report is that the suicide rates have only increased slightly since 1975, and in fact they've increased to about 4.5% among 100,000 youth. But what I'd like to say is that the CDC presents that there's been a doubling in the amount of suicide that's occurred probably over the last 40 years in both adults and teenagers. And I would certainly say this mirrors what I'm seeing in the clinical practice, which is more and more young patients that are presenting with both anxiety, depression, or suicide attempts. And what we know is that suicide is currently the third leading cause of death among our young patients, and in fact, it accounts for about 11.2% of all teenage deaths per year. And according to the Youth Risk Behavior Survey, that's about 16.9% of our young students that consider suicide in the last 12 months. So on a particular day, we have a number of our young patients that are very depressed or certainly thinking about suicide, and certainly in specific populations, as mentioned earlier, among Native American youth, for example, those rates can be much higher. I'd like to use another illustration about another patient of mine whose name is Mark, and he's a Hispanic male, as an illustration of some of the issues that we see in terms of depression. Mark came to me because he had a history of depression, in fact had been hospitalized for depression. He has a family history of depression. His mother is a single mother. She's Hispanic and does not speak English very well. The father is not involved. Since he came to see me, he actually had a change in his insurance. He had initially been on medications for his depression, stopped receiving the medications because they lost their insurance coverage, and then actually stopped seeing a psychiatrist and a psychologist because, again, they had lost insurance coverage. During the time that I first met him, he had dreams for his future. He talked about the fact that he wanted to join the MBA, he wanted to graduate from high school. And over the time that I've met him, and since the time that he stopped receiving some of these other supports, he's been very disillusioned. And in fact, his grades have gone from B's in school to probably D's. There are times where he doesn't make his appointments. There are times where he feels very distraught and very unhappy about what the future really has to do, what the future really has to hold for him. And I think that with Mark, we also struggle again because of insurance, because of barriers in terms of communication and cultural issues, because sometimes of cultural stigma in his own community to really understand what depression is and what suicide is, that there are significant barriers to helping him to really get the care that he needs. And there's so much that I think has to also go to the fact that a lot of our teens aren't receiving the mental health resources that they need. In fact, one study showed that only 10% of our teenagers are actually getting the resources or getting adequate treatment for mental health. So I certainly think that there's much that we can do, particularly in the issue of mental health, from a policy level, certainly increasing the amount of research that's done in specific populations, increasing insurance coverage for our teen patients, and certainly increasing the amount of resources, particularly in schools and other communities, to help young people to screen for them and to provide the resources that they need. So I've outlined two issues which I think are very important when it comes to our teen patients, the first being obesity and second being mental health. I think there is so much that, again, is wonderful in working with teen patients that we can do. Certainly in my own practice, it's very gratifying when I can work with a teen patient and to get them to perhaps not become pregnant, get them to maybe graduate from high school, stop using drugs. But I do think that our work is not over, and I think both on an individual level and also on a societal level, there's so much that we have a responsibility to our generation Y, or the current echo boomers that we have here, to make sure that their generation is a healthier one than their parents and their predecessors. So thank you.
Thank you, Dr. Abraham. I think about the importance of motivation to psychology and also to obesity. And this Thursday in the Education and Workforce Committee in the House of Representatives, Richard Simmons will be testifying on obesity and providing a new kind of motivation, I think, for the congressman. But I think the broader piece here of the practical nature of the work that you do is very important, and that's a very important perspective. A third speaker, Anita Berger, is the principal at Benjamin Banneker High School. I got to know her a bit when the very first winner of our inaugural Improving the Lives of Children contest that we ran for all D.C. high school students, and we'll be running nationally next year. The first winner was one of her students, so we had the pleasure to be at her high school to present that award, and we have the pleasure to have her here to speak to you now.
First of all, I would like to thank New America Foundation, not just for this opportunity, but for supporting the Banneker program in other schools in the city. I'm going to focus, first of all, Dr. Land has done an exceptional job, as well as his colleagues, with this report. And again, I'm becoming more and more familiar with it, so it's good to know that this and other information is out there to help us work with students that we work with every day. I'm going to focus my comments on educational attainment, and I specifically wanted to work with that because I'm not sure how many of you know about Benjamin Banneker, but just to give you a little backdrop, Benjamin Banneker Academic High School was first created in 1981. It was a vision of one of our superintendents to create a model high school that would focus on getting students into college. In 1983, the first graduating class The students there, it was 100% graduation plus 100% college acceptance. And since 1983, we have had 100% college acceptance and 100% graduation, obviously. So we've had a really high level of success. Our class of 2008 that just graduated netted over $5 million in scholarships, and each student had at least 5 college acceptances. So we're very proud of what we've done at Banneker, and it's a little different from what you hear in the city that's going on. But yes, we are a public high school. We're actually located in Ward 1, 800 Euclid Street Northwest, and we receive students from all over the city. So it is a special application process, but there is a common goal that they want to go to college. And so we're really working hard to try to maintain some of those things that will make sure that our students continue to be successful. So it is really a challenge, and you know, I want to first focus on the test scores. Being in an environment where test scores are already high, our students come in with pretty good test scores, but we are challenged with the fact of moving them to advance. So they come in proficient, but how do you get great kids even greater? And that's what we've worked on. And you know, the trend that was highlighted in the report, that actually students are testing a little higher than their parents, I think some of that, and you'll see maybe more in later years, is contributed to the controversial No Child Left Behind. But there are some great things about that, and we see them, but we also see some things about that program that impacts Banneker in several different ways. I want to first talk about, we, again, have kids coming and being successful, but our population serves about 95% African Americans, 2% Hispanic, 2% Asians, and about 1% Caucasian students. So we have a wide variety of diversity. 40% of our students are free and reduced lunch students. So what that says, 40% of our kids come to school and they make sure they have lunch. And I talk about this young man one day, and I noticed in the cafeteria that he would wait until the last lunch tray was left on the counter. And, you know, I said, Kevin, he looked at me, he said, "Can I have that?" I said, "Absolutely, no one's going to, you know, take that." It was at the end of the lunch period. He said, "Ms. Berger, you have to understand, I come to school so I can eat." So at that point, I made sure that there were a couple of lunch trays left for him, and that was our secret. But he is now in a med school program, so I'm happy to hear that he is going to be successful. Again, when given the task of moving great kids even further, we worked on a program that currently has our test scores, and I think recently have been publicized, but in the DC CAS test score, Banneker students have come out with a 98% proficiency in mathematics. And in this day and time, I commend my faculty and my staff who work with the students. But not only are they 98% proficient in math, but 42% of those kids are advanced. And that's an increase for 20% from last year. We had 22% that were advanced, but that's an increase. So when you look at students of all types of diversity and backgrounds coming in, and they work even harder to be even better, we're doing some things that are working for our kids. So as far as reading, we have 97% of our students that are proficient in reading. Out of that group, we have no African American males that are basic or below basic in reading. And again, that's a subgroup. So we've been moving subgroups. And so we're really proud of what we're doing there, but it is probably the most difficult job to get great kids greater, because when you're lower at the totem pole, you can see movement better. But we're really working hard with these kids. What we've tried to do is expose them to the most advanced programs as possible. And research supports that the kids who are exposed to advanced coursework will more than likely go to college and more than likely will graduate within 5 years. So we have seen that. We look at, once they go to college, how do they survive? And with the economic, challenges today, what do we do? How do we work with our students? Again, I mentioned this year our students of 74 graduates netted over $5 million in scholarships. That's a lot of money. And they need that money because, again, they're from those families that are in poverty, and this money is going to get them where they need to be. In 2007, we netted over $4 million in scholarships. Now, when you look at scholarships, there are 5 different categories in which those scholarships come under. You have scholarships from post-secondary schools, institutions, you have alumni scholarships, you have scholarships from churches and religious organizations, fraternities and you know, sororities, and from community organizations, grants, and campus-based scholarships as well. And then you have Category 5, which is an institutional offerings. If we look at the data in which our students have been receiving scholarships over the years, I'm not going to go through all of these years of data, but looking at 2007, scholarships were over $4 million, but from those institutional offerings, $1.6 million. And in 2005, category from those institutional offerings, Category 5, we had over $3 million in scholarships. So although they're getting the scholarships, but there's a trend in which those institutional offerings occur. So even in 2000, we had close to $4 million in the institutional category as far as offerings for our students. So it's reasonable to report that, you know, we cannot predict what our students will get in '09, but because of, you know, the different variables such as the economy, the strength of maybe each student's records, and the motivation of the students, and the money that's available, you know, out there, period. But we're trying to continue that trend of offering these scholarships because we know the students need this in order to be more successful. And again, some of these are first-time generation college students, so we want to make sure that that continues. This morning, ironically, I read my email at 5 o'clock in the morning because sometimes you just can't get to it any other time. And I received an email from a grandmother, and I'm just going to call her Grandmom Lenora. And it was just so, I said, I have to share this with, you guys today because I thought this is exactly what is kind of answering, are we better off than when, you know, our children, are they better off? So she writes me, she says, Dear Principal Berger, for the past several months now, many Southwest D.C. friends and acquaintances of Neo, I'll just name her Neo, a recent Banneker grad, have been celebrating her recent honor. Elected student government president at Grinnell College in Iowa, commencing upon her senior year. As one proud woman who played grandmother in her life, and I just want to say Grandma Lenora was the mother because, again, mom wasn't available, or, you know, she's from the grandmom household. She says she wanted to share this wonderful news with the Banneker family, especially those who worked with and guided her to this level of accomplishment. Students, teaching staff, and administration need to know that graduates must believe unconditionally that there are many, many opportunities out there for them, but they must prepare themselves well to receive and take advantage of them. As you know, there are schools that don't really offer the academic environments that we once knew. So she's saying this, that we are bombarded with so many negative news about our youngsters. However, there must be channels out there where institutions like Banneker capture and spread the good news accomplishments of their graduates. So then she goes on to talk about how she would like for me to share this information. So I said, you know, after I share it, I'm going to call and let her know I definitely shared her information. But just to speak about her granddaughter, she was one of 12 seniors that received a scholarship offering called the Posse Scholarship. And those students were high school students who were chosen for full tuition scholarships at schools such as Bucknell and Grinnell. And so out of the 12 students, actually the year that her granddaughter graduated, we had 5 Banneker students that received these scholarships. These students also had to have a poverty-based income. So with those 5 students, and she has done so wonderfully, she has received so many recognitions, and this is from the Grinnell College Student Government Association. Grinnell College students recently elected Neo as president of the class of '09. And congratulations, and what makes Neo so, again, special, being raised by her grandmom from Southwest D.C., she has beat the odds. And we have to continue to provide that information and the things and provide environments in which our students know that there are opportunities available. But it's a consistent and constant battle when it comes to making great kids greater, making those kids that are not that great greater. So we have to support it, and I think it's a sense of community that we must bring back. And again, the information in this report definitely supports some of the things and the needs that we'll have in the future. Thank you.
Thank you, Anita. I'd like to invite Kelly Kay to come forward, a good friend and colleague and one of the leaders in the research area looking at teen pregnancy. Kelly, please. Yeah, why don't you sit back?
Great, thank you. Thank you so much for the opportunity to be here today and be part of such a distinguished panel. It's especially nice to hear the presentations of Dr. Berger and Dr. Abraham. I think their stories help remind us of the real teenagers that are behind these statistics, and that their lives are very important and very inspiring and very complicated. I'm going to take us back up to sort of 60,000 feet for now, talk about some good news but some sources of concern. But I want to make very clear up front that even when I sound off some warning bells, this isn't about blaming teenagers. It's not about saying that teenagers are bad, but it is about keeping all of us vigilant, that we can't say, okay, we're all done, we don't have to worry about this young generation of people anymore. So first, a little bit about the good news. As Dr. Land pointed out, the teen birth rate has been falling phenomenally, and there's a lot of good news here. This chart actually shows us an even longer historical perspective, all the way back to 1940. Of course, it's a little hard to interpret trends going back this far because the societal and the familiar context around teen childbearing is so different now than it was back during some of, whoops, that's not what I meant to do, during some of these earlier periods. You know, even back in the 70s, a lot of the teen births that we saw were actually to married parents. Family formation just started at a much earlier age. But you know, during the early 90s, of course, here a lot of these teen births are to unmarried teenagers. They are unintended births, and it peaked at a high of 61.8. But now it's much lower than it had been. And so we're very encouraged by that. And it's also the case that teen childbearing has fallen not only overall, but among the unmarried teenagers as well. So while we've had a decline of 34%, so a little better than a third between 91 and 2006, even among unmarried teens, we still have a decline, a little bit smaller one of 24%. More good news, the declines have been relatively across the board in terms of racial and ethnic groups. The smallest decline has been for Hispanic teens. One of the largest declines has been among African American teenagers. Let's see, so again, we saw teen birth rates decline by 48% among African American teenagers between 1991 and 2005. That tends to be the period that we focus on quite a bit because it's marking it from that big increase. But it is also lower than it was even back in the 1980s. Let's see. So we have a 48% decline for African Americans, 37% decline for Native Americans, 40% decline for non-Hispanic white teenagers, 38% for Asian American and Pacific Islanders, 22% for Hispanics. And again, the overall decline was 34%. These are not trivial numbers. And again, they're fairly across the board. More good news. Of course, if teen births decline, we're never really sure if that means that teen pregnancy declined or simply that teenage girls who become pregnant are less likely to carry those births to term. Teen pregnancy includes those pregnancies that are carried full term, those that end in abortion, and those that end in miscarriage. And happily, what we see here is that the pregnancy rate itself has also been falling. And so again, more good news. And it's quite a bit lower than it was even back in 1972. So yes, these kids are better off than their parents were. And it's a phenomenal decline. So a steady decline through 2004, decline of 37%. So this is, again, very, very good news. These declines, as with teen births, the declines in teen pregnancy are also shared across most racial and ethnic groups. Declines in teen pregnancy since 1990 for African American teenagers, 46%. For Hispanic teenagers, 25%. For white teenagers, white non-Hispanic teenagers, that is 48%. And overall, a decline of 38%. So all this is very encouraging. So this just really puts it all together. We have the teen pregnancy rate. We see falling, again, quite a bit from 1972, and that translates into both declines in the teen abortion rate and declines in the teen birth rate. Why do we care about this? Of course, we could talk all day about that. Teen pregnancy is definitely linked to a number of an increased risk for a number of difficult outcomes for young families, higher rates of poverty, a number of difficult outcomes for the children to teen parents, poor school outcomes. As I said, we could go on and on about that. The Brookings Institution did one interesting study. They took a little bit different take on it, sort of projecting what would happen if we hadn't seen this decline in teen birth rates. And they projected that if we hadn't seen this decline since 1991, we would have 1.2 million more children born to teen parents. We would have 460,000 more young children living in poverty in 2002, and we would have 700,000 more young children living with single mothers in 2002. These kinds of numbers can be helpful for policy organizations like us, for example, when we go lobby Congress for more money to prevent teen pregnancy and to provide services to adolescents, because it helps them see in a very aggregate, big picture way how these kinds of services for adolescents can make a difference. So all this sounds very encouraging, and it is. Why are we still a little bit worried? Well, even though the rates have been falling quite a bit, they're still very high. And we are much higher here in the United States than we are compared to almost every other industrialized or sort of developed country in the world. And of course, everybody says, well, we can't be like it is in Scandinavia. We're never going to be like Scandinavia. But even if we compare ourselves to the United Kingdom, a country with which actually in terms of economics and social structure, we have a fair bit in common. Our rates are almost 40% higher than they are in the UK. And so this indicates that we still have a very long way to go in terms of serving our adolescents and helping them secure their own futures in a better way. Another reason for our concern, this is a slide you just saw. We had focused before on the decline, both going all the way back to 1980 and the huge decline since 1991. But let's look at 2005 to 2006. We see that little uptick there. Lots of conversation around that little uptick and what that means. And Dr. Land alluded to this in his very excellent presentation as well. Why is it going up? Well, why did it go down during the first 15 years? Why is it going up now? we can have a full day conversation around that as well. I'll save that for the question and answer period if people want to get into that. Short answer is it's complicated. It's a little difficult to know so far with only 1 year of data just what to make of this. But for sure, even if you look back over, say, from 2000 to 2006, we see that it's attenuating. We see that it's leveling off. It's plateauing. And plateauing was another theme that Dr. Huang talked about in her presentation. It could be that all of the easy wins have been won. It could be that we really need a new set of tools to try to further bring down these indicators that we're concerned about. And so, maybe next year it'll tick up a little bit, maybe it'll tick down a little bit, we're not quite sure, but we're not continuing to make the same progress that we had before. And that in and of itself is a concern. And we see that uptick also happened across the board, except for Asian Pacific Islanders, just like the earlier declines did. What might be behind that increase? Well, from a simple compositional, there are two different kinds of answers to that. One is, if kids are getting pregnant, it's either because more of them are having sex, or more of them are having sex and not contracepting effectively. That's basic biology. And so we see here, again, a small uptick in the proportion of sexually active high school students. This uptick was for both boys and girls. Same story, what we make of that uptick is up for speculation, but we see that those earlier declines from the mid-1990s have started to attenuate. We're not continuing that same level of progress that we were before. Similar story in terms of another risk indicator, proportion of sexually active adults who've had 4 or more partners. This is an important indicator because the more partners adolescents have, the less likely they are to contracept. And so they're sometimes at the greatest risk for teen pregnancy. Same story, uptick at the end. Overall, we're better off than we were in 1991, but it's starting to go up, and that earlier progress we saw is starting to disappear. Last slide, and this is just kind of putting it all together in one graph. So we have whether or not they had sex, whether they had sex before they were 13, another very strong risk indicator for becoming pregnant, because they tend to have much older partners and tend not to contracept. Whether they used a condom when they did have sex. Overall sexually active had 4 or more partners, and whether they used a birth control pill at last sex. All of these are moving in the wrong direction, but again, it's a little hard to tell where it's going. I think the takeaway message is really that, yeah, we are better off than we were. But we can't just give up and become complacent and say, okay, we've solved that problem. The sources could be anything from the media, as Dr. Land mentioned, overall complacency, lack of funding for sufficient programs to serve our adolescents. It's probably a little bit of all of those. And so the solution will probably need to include all of those. And at the very least, there's a sign here that we have an unmet need to serve our adolescents better than we are. And that's all I'll say for now. Thank you so much.
Thank you, Colleen, and thank you to all of our panelists. I have a number of questions in my own mind, but I'm going to save them, and I hope we can, the presentations have stimulated some in yours. I'd encourage Ken to come up here as well, and if you have any questions to any of our respondents on any of their work or how they see the index in their work or the future, or questions to Ken around his work and more information on the data and what he developed and where it's leading us, or more impersonations of George Carlin, fire away. Yeah, Bill.
I'm Bill O'Hare
Yeah.
with the Annie Casey Foundation.
Yeah.
This is for Dr. Huang.
Huang.
Sorry. One of your slides seemed to say that 37% of alcohol sales were to youth. Did I misunderstand that, or can you say a little more about that?
Yes, we
the significant number of percentage in the beverage industry is targeting sales to youth, to adolescents. And so they are significant purchasers of, and we find actually that oftentimes it's parents who actually help them purchase. So one of the things as we look at the bigger picture, and as we're trying to have an impact on youth behaviors and messaging about underage drinking, there's another whole arena that we also need to target in terms of they are actively marketing to youth when we're trying to actually do prevention.
Interesting.
Am I correct in interpreting that more than 1/3 of the alcohol consumption in the country is to 15 to 20-year-olds? Is that something?
It's to 12 to 19-year-olds, 12 to 20-year-olds.
Is that amazing?
Yes.
Amazing, amazing. I mean, it brings up mind, just to follow up on that, Laura, in your presentation you emphasize the importance of partnerships, and I remember you saying it's not just for the medical system to think around how we solve problems, that public needs to get involved. I guess I would ask you, and perhaps Dr. Abraham also, you know, we've had some successes. You talked about the public success in dealing with a variety of teen problems in the past. From those public campaigns, you know, I think about cigarettes and other things, for instance, are there things that in your work that you take away from those other successful public campaigns that ought to be applied, perhaps in your work, to teen drinking, for instance, which, as Bill points out, remains a problem? And then, Dr. Abraham, in your work on obesity generally, thinking clinically about your patients, that we can apply from the public campaigns and the public work that the society's had success in other areas that you think, if applied to the area of obesity, could have some success. So, either one.
Well, we often look at large-scale public health campaigns that have been successful, such as seatbelts and declines in tobacco use. And they've all been sort of multi-pronged efforts. No one sector has taken it. It's really been a lot of partnerships across. Media has been very critical. Media, the education, information, public awareness campaigns, but also looking at other partners in the community. We actually look a lot at merchants. We look at merchants and how merchants are messaging to kids about sales of alcohol or sales of tobacco. We look at tremendous sales in convenience stores, and also tremendous sales in convenience stores near gas stations that are selling Alco Pops and all different kinds of things that I didn't know what they were, you know, as a parent, but the kids do know this. So I think it's been partnering there. It's been partnering with education, with schools a lot, and also with law enforcement. Law enforcement is not always a ready partner we think about in terms of mental health or substance use issues, but oftentimes they're the first responders, you know, and if they can see kids in crisis or they can look at early warning signs. And then we're really looking at community leaders a lot in terms of really getting community leaders in their communities, because they help us do the messaging and help know what are the interventions that are going to work the best. So it's not just sort of our regular providers of care, but a lot of other different kind of community-based institutions and organizations.
Thank you. Dr. Abraham?
I agree with Dr. Wong that the model of teen driving, and certainly what we've seen in terms of some of the changes from a public health standpoint, have been very helpful and certainly can be applied as we talk about teen obesity. In particular, we know that with the advent of increasing seatbelt use, we know that there's been a decrease in the amount of teen car accidents, and motor vehicle accidents, again, is the #1 cause of death for teenagers and certainly a preventable cause. And we're seeing more and more information now about graduated driver's licenses, particularly here in DC, Virginia, Maryland, that you can restrict the time that teenagers are driving, who's going to be in the car, whether or not they're using a cell phone. All of these things actually will also decrease the risk of teens becoming involved in motor vehicle accident. These are all public health regulations, certainly things that we can use with law enforcement and from a much more societal standpoint that decrease the rate of deaths. As we talk about then applying that to teenagers and obesity, I think there's so many different arenas that we can incorporate it. One, just working at a high school here in DC, I can say it's soda machines and the access to food that we see in a lot of our schools. And there has been significant changes, and particularly in the high school I work in now, there's less ability for teenagers to actually buy soda and to buy juice. It used to be that was the only thing that was actually available, and now you're seeing more water and less carbonated beverages and other things are available. But that used to be the only thing funding that was available in a number of the schools. And so decreasing that, I think, can certainly help. Other changes, increase the amount of physical activity, again, giving more funding to increase physical activity, because we certainly have seen there's been a nationwide decrease in the funding and amount of physical activity. And I heard a wonderful report this morning on NPR from the Wall Street Journal that in one community in Los Angeles where 30% of the teenagers and adults had rates of obesity and overweight, they're trying to restrict the amount of fast food restaurants in that community. And I think that's a very interesting intervention, and certainly something that we'll be watching for, that a community wants to not allow more fast food restaurants in there because they think there's such high rates of obesity. So I think there's a lot that we can do from a public health standpoint to decrease obesity.
Thank you.
Can I make one comment?
Sure.
I think Dr. Abraham spoke nicely about the built environment and how that really impacts what you're going to have access to in terms of nutrition. And New York City now is partnering with the city and foundations to put vendors that are calling them green carts. So they're putting vendors in neighborhoods that don't have all the fresh produce in the supermarkets that Dr. Abraham was alluding to. So they're doing economic development by giving community people vendor carts to run, and they only are selling fresh fruits and vegetables. You know, so that's kind of another sort of public health approach to get at what you're talking about, access to good nutrition.
Yeah. I did a radio interview on this last night, and they asked me about, is there any connection with this to energy? Because all they were so focused on right before the gas prices. And if kids all walk everywhere, you know, and ride bicycles, or we all do, it will have an impact on the health. Further questions? Yes, please identify yourself.
Carabelle Pizzicati, I'm an independent policy analyst, and I'm the current president of the National Association of State Boards of Education. So I appreciated the focus on making sure that we have multi-pronged strategies to address some of these issues. Thank you, Dr. Land, and thank you, panelists, for your commentary. My question has to do with, in addition to multi-pronged strategies that can really impact, that is, make better, those areas where we are not seeing as much progress as we would like, and certainly maintain progress in those areas where we are achieving some success. The importance of the data in doing that, in making relevant and making more visible the issues that are key issues to not only the population severely affected, but clearly for the public at large. I was pleased to hear Dr. Bung and Dr. Kay and Dr. Abraham refer to the Youth Behavior Risk Survey, and others of you refer to other data sets. And these data, I think, are terribly important, not only the domains illustrated in the Child Wellbeing Index, but as you dig a little further beneath those major domains, the data that can support that and that can make the case. And certainly Ms. Berger and Dr. Abraham putting a face and faces on the issues that need to be addressed is terribly important as well. And I would like the panelists, if they could, any one or more of them, to speak to how the data are used in making that connection between raising the awareness of the issue and then securing in whatever environment in which you work action to, in fact, bring together in an interrelated way the kind of multi-pronged approach to address the problems going forward. So it's really, how do you use the data? Are you using it in a way that speaks to both relating it in the community and advancing progress in particular areas?
Great. Very interesting. Yeah, data-based decision making. Anybody see data-based decision making in their work as particularly helpful? Kelly?
I can offer one, well, of course, there are many, many examples, and thank you so much for elaborating on this point. We had one informational campaign a couple of years ago called By the Numbers, and what the campaign did was come up with actual cost estimates around what it costs at the national and at the state level, rather what those costs are associated with teen pregnancy. And we got a fair bit of pushback on it. It's always a mixed bag. There were concerns from, I think, a lot of the child advocacy communities and the teen pregnancy prevention communities and the communities that serve teen parents that we were vilifying teen parents by showing that it's an expensive proposition for the national and the state governments. And that, I accept that, that's valid, but having those data that said this costs your state X number of dollars, we heard from so many state legislators that they were able to go to their state governments and successfully lobby for additional funds, because the people that sit in those state legislatures have to make a case to spend money on this thing as opposed to something else. And so to be able to say we would be able to save X number of dollars if we invest in this, we were also able to use those numbers to go to the business communities and some of the health insurance communities to get them to invest more in family planning services across the board. Being able to put a dollar value on it, like I said, while it's a little bit of a mixed bag, really helped us reach out to some of those communities and get them to invest in some of the services that we wanted to provide.
Great. Further questions? Gentlemen.
I'm Hunter from Hindenburg I work for the World Bank.
Uh-huh.
I had a question for Mrs. Kay and then also for the author, Dr. Land. And I want to take up Mrs. Kay on the invitation to discuss the reasons behind the decline in teen pregnancy in earlier years and then maybe the latest uptick. She promised that we could talk more about this in the Q&A, and I would like to hear the reasons for that. It would be intriguing to know. In the same vein, when Dr. Land showed the initial slide, or the historic slide from 1975 through 2005, it looked as if the well-being of teenagers was mirror imaging essentially the GDP growth in this country, with a decline in the late 70s, early 80s, and then going back up, which would lead me to believe all we can do, or the best thing we can do for teenagers, is to grow our economy. Is that really the main conclusion, or what's really, again, behind these rises and declines in overall well-being, and also the rises and declines behind teenage pregnancy?
Very good questions. Thank you. Colleen, do you want to take it in order?
Sure, and I'll leave it up to David how much time he wants to talk about this question. But I think that in terms of both the decline and the uptick, there are two different kinds of answers. One is, what are the changes in behavior that led to those trends? And the other is, why do we think those behaviors are changing? The first question is much easier to answer. Again, if teen pregnancy is coming down, it's either because fewer kids are having sex, or if they're having sex, they're contracepting better. There have been a few different studies on how that breaks out. Depends a little bit on your political leanings and your policy agendas, where you fall along that spectrum. Some studies say it was roughly 50-50 in terms of fewer kids having sex and more kids contracepting better. Other studies say it was more like 25-75, weighted more heavily toward the increased efficiency of contraception. The uptick, again, it's only 1 year, and the data on the behaviors lag. So we don't have, well, no, that's not true. They don't lag. We do have it up through then. It would seem to be that there's both a small increase in sexual activity and a small decrease in contraception. That's pretty straightforward. In talking about why kids are having sex more often or contracepting less effectively, you have to get into the head of every single teenager almost. There's a number of hypotheses out there. We certainly look to the media. There's been a media storm this last year or so with movies like Juno, outcomes like Jamie Lynn Spears. We talk about this sort of celebrity baby bump factor that we're kind of glamorizing, either single parent pregnancy or teen pregnancy. There's a sense that our society's gotten a bit more complacent. There's a lot of debate as to whether the focus on abstinence education has contributed to this increase, although, and that could be another whole day debate, but it would seem as though that hypothesis actually is not borne out in the timing of these trends and in terms of how widespread it is across states. It would, I think, probably one of the reasons why we're increasing, or at the very least attenuating in terms of this outcome, is that it's just become much more normative behavior. And while we certainly never want to stigmatize young people regardless of their outcomes, the fact that having a teen birth is now more normative than it used to be certainly contributes to this increase, or one could hypothesize that it does.
Correct. Very good. Ken?
Good questions. Certainly, if one looks at the subdomain family economic well-being, there is a strong positive correlation with ups and downs in the national economy. However, the overall composite CWI shows long-term recession, decline in the 1980s, even though there was an expanding economy. So the overall CWI is not highly correlated with trends in macroeconomic conditions. I would like, since I have a moment, to speak about something else. And the thing strikes me, Principal Berger's presentation, best practice, the enormous best practice in this high school. And question that comes up is how can more of us, more institutions, more organizations get to this, the best practice frontiers with respect to child and youth well-being, delivery of services, and indicators of outcomes. And I want to relate a story. Back about 15 years ago, the Administrative Office of the Courts in the state of North Carolina asked us to do an evaluation study for an experimental treatment program for adolescent status offenders. Status offenders are kids below the age of 16 who are truant from school, who are unmanageable as considered by their parents, reported to the courts, the kids don't come home or don't obey me or whatever, or seen in places they shouldn't be, like bars and taverns and so forth. And progression to delinquency was the ultimate outcome criterion for the program. And the standard practice is to assign these kids to a juvenile court counselor who has 40 or 50 cases at any given time. So about all the counselor can do is maybe a telephone call a week or something like that. The experimental treatment was to reduce the caseload to 8 to 10 cases per counselor and to provide counselors with backup services for diagnostics and treatment. And the Administrative Office of the Courts actually got about 6 juvenile courts around the state of North Carolina, the judges to go along with random assignment of the kids, the ultimate gold standard for evaluation research programs. We did the evaluation study for the first year and a half, and we found nice experimental outcomes, reductions of progression to juvenile delinquency on the part of the status offender kids in the experimental program. And we actually published an article on that first year and a half of the study. Unfortunately, as the officer in the Administrative Office of the Court said, he let us go for another year and a half. And so we had a full 3 years of data on experimental treatment outcomes compared to case controls. And in the second year and a half of the study, the experimental outcome decayed and disappeared. And so we had to look deeper and ask, well, what's going on? And it turns out when you have human service delivery programs like high schools, it's not just the subjects who are important, it's the people who deliver the services. And during the first year and a half of the program, the court counselors were revved up with education programs, conferences, attention by the Administrative Office of the Courts, et cetera, et cetera. And so they were revved up and they delivered those services. They were convinced they could make a difference in the outcomes for these kids, and they did. In the second year and a half of the program became bureaucratic. The court counselors got less attention. Maybe there was counselor burnout. You know, it's an intensive process to deliver these services to kids. It takes a lot of time and effort and emotional involvement. And so the consequence fizzled out. Now, if you abstract out of that circumstance, perhaps you can understand, for example, why faith-based programs turn out to be quite effective compared to other types of programs. What happens with faith-based programs every weekend with religious services in the temple or the church or the religious institution? What do? Basically, you rev us up and convince us that we can make a difference in people's lives. And so there's a continuing infusion of the energy and the ideas that it takes to indeed deliver the human service and to make it effective. And I would suggest that probably what Principal Berger has succeeded in doing is continually revving up her teaching staff in such a way that they're at the frontier, the best practice frontier with respect to high schools.
Appreciate that, Ken. As we're now at 12:15, I want us to close on time. I want to give the last word to Ms. Berger here, just for one word. A lot of folks in this room, certainly on the panel, but in this room, work with kids either in the trenches or research for kids. And there is an area of like with every other thing else, where we need motivation. From your work directly with the kids, for folks who aren't working with kids but are studying this issue, what's one word of motivation and hope that we should have when we do our work in this area from your work on the in the school?
Commitment. And I say commitment because unfortunately what I'm not seeing today is the 25-year I'm in education for the long haul. You don't see that commitment any longer, and that's probably been one of our challenges, holding on to the tradition. And we just need to be committed to our kids. And you know, I look at some of the success of the program, and it's a sense of community. We have a lot of community involvement and community support. Our students do 270 hours of community service. So that community appreciates and they give back and they support our program. Commitment to our youth, and I think that's the biggest piece. We can't use education as a stepping stone to pay off our student loans. It has to be, you have to be in it for the long haul, through the heart, and it is not an easy job. It's probably one of the most difficult professions that there is working with our youth today. So once they find people that are in it and they trust, I'm sure someone here can think about, there's been a teacher that touched your life one way or another. So we could get more commitment in terms of education and those who are working directly with our students. And we kind of, you know, we look at being service providers. And one of the things I tell my students, I work for you, tell me what you need. And that's how, you know, I approach them.
Very good. Thank you very much, Dana. Thanks to all of our panelists. Thank you for all for coming.